Hi, this presentation is going to be about blood transfusion safety with directional leadership in transfusion medicine. At the end of this presentation, the student will be able to explain and define patient blood management, diagnostic management teams, hemovigilance, and doctorates and clinical laboratory scientists, as well as blood bank specialties. They will be able to list some of the treatment options available for anemia, recognize medical errors and know that teamwork will provide better patient care, recognize implications seen with transfusions, and recall the leading cause of transfusion-related death. They will also be able to apply this knowledge to assist with providing better patient care, analyze and hypothesize costs in their own individual facilities, and conclude that teamwork and implementing patient blood management programs, diagnostic management teams, and bringing in specialists will reduce costs and increase patient care. Blood transfusion safety. So hemovigilance, we're going to talk a little bit about exposure and errors, and then patient blood management, about the guidelines and the cost. Although patient blood management and hemovigilance are very much alike, patient blood management tends to hone in on actually how to implement hemovigilance. And then we have diagnostic management teams where they are a part of a team of clinicians, experts, specialists, doctorates in clinical laboratory science, but overall working as a team in reviewing patients' charts in order to provide better patient care. Here are some terms that we will be mentioning: hemovigilance, patient blood management, diagnostic management teams, and doctorates in clinical laboratory science. Hemovigilance, exposure. Being exposed to unnecessary blood products is really something you want to obviously not have happen. You want to reduce that exposure just because that you may result in adverse effects, may delay patient care. The average reimbursement as well for blood products is a lot lower than what you would expect, so you kind of want to avoid unnecessary costs for both patient and the hospital. Just with the FDA alone, we've number one cause of death related to transfusion is TACO. You can see where it's broken down here into definite, probable, possible, but overall it's a large number of patients dying due to TACO. Now, could those have been eliminated? Be interesting to know. Could we have treated them some other way and they'd still be alive today? Something to further investigate in the future. Trolley is the second leading cause of death, and something that's interesting about trolley is the fact that most blood donor centers have reduced the number of female donors for platelets and plasma just to try and lower the cases of trolley. However, most of the trolley cases from the FDA were all from red cell transfusions, so it can't be completely eliminated, and again, it's still top up there with TACO. And then you have anaphylaxis, and as I was reading through the FDA, it pointed out that many of the previous cases that they had investigated possible IgA deficient, they found that most of these patients were not IgA deficient. They did not screen those for 2017. However, it very well may not be the culprit, and it could even possibly be haptoglobin deficiency. I know they had checked some of those and found that some patients were deficient in that. And then, of course, you have pathogen contaminations. You have a few different ones. You have the Enterobacter aerogenes. Might have said that wrong. Coag-negative staph, Pseudomonas, and Babesia. So, there's so many things out there that we just can't account for, but yet we can prevent from happening if we can find other treatments. Some of the non-fatal cases, of course, is you got your febrile. Again, you've got TACO, 1 in 100. You have allergic, 1 in 250. transfusions, TRALI, hepatitis, Hep B, HIV. Based off of the AABB report for 2013, 6.1 million units of blood was transfused. And if you take that into account, say for example HIV, approximately 4 patients every year will get HIV. Now that doesn't seem like a lot. However, if it was you or your family member, it would be a big deal. Same with hepatitis C. Approximately 40 people get hepatitis C from a transfusion annually, based off of the 2013 data from AABB survey report. And on with errors, transfusing patients unnecessarily is a medical error. 75% of death-related transfusions with hemolytic transfusion reaction was a result of a medical error. Again, it'd be really interesting to see if these patients really even needed the blood to begin with. Hemovigilance, patient blood management. They're very much the same. From what I have gathered, it seems like patient blood management, of course, they focus more on the guidelines, they give the details, people get accredited with them, they provide more of the tools. Hemovigilance is just more of a definition of what it means and the understanding of it. So when should you transfuse? Based off the AABB guidelines, hemodynamically stable patient, including critically ill patients, they recommend that those with a hemoglobin of less than 7. Now, orthopedic and cardiac surgeries, they suggest that the guideline be less than 8. Now, the hematological and oncology patients really have no established guidelines. Same with severe thrombocytopenia and chronic transfusion-dependent anemia patients. There's really no guidelines. So how much should you transfuse? Evaluating pre and post, those are all really important questions and really important things to know. So, you really need to know what someone's values are. Now, I'm focusing on hemoglobin, so I'm focusing more on red cells, but, this goes hand in hand with plasma and platelets. What's the patient's INR, what's the patient platelet count, what's their clinical condition to make those decisions. But overall, the focus is hemoglobin level pre and post to evaluate when a patient should be transfused, how much they should be transfused, and evaluating this after 1 unit, not the traditional 2 units. We also need to focus kind of on the prevention and alternative options, such as iron supplements, EPO, treating the underlying disorders, waiting on surgeries until anemias are treated, and using lab specialists to help with guidance on transfusion criteria. So you have a patient who comes in for blood work, you don't just leave it at that, say, oh, the patient's anemic and send them on to surgery. The goal is, ideally, those elective surgeries, maybe they can wait on until those transfusions or the anemia is treated. And so that's what the goal is of patient blood management. So it's not just about the hemoglobin levels. This is a good clinical practice statement that I had also cited in my paper. When deciding to transfuse an individual patient, it is a good practice to consider not only the hemoglobin level, but the overall clinical context and alternative therapies to transfusion. Variables to take into consideration include the rate of decline in hemoglobin level, intravascular volume status, shortness of breath, exercise tolerance, lightheadedness, chest pain, thought to be cardiac in origin, hypotension or tachycardia, unresponsive to fluid challenge, and patient preferences. This patient guidance is not intended as an absolute standard and will not apply to all individual transfusion decisions. It's really important because I think patient blood management, you hear a lot about the hemoglobin levels and what the recommended thing is hemoglobin, but you really have to look at the overall clinical picture. And this is kind of why you really want to involve the specialists and build teams to help provide better care for patients. Just cost alone, in an intensive study, they found that the average cost to transfuse units is $469 to just over $1,000. It just varies, obviously, on different hospitals and locations. but on average, that's about what it costs. And some of those steps, you remember that's being included in this is just the ordering, so that clerical area, processing, phlebotomy, testing, adverse events, and long-term effects. And something that's not even included in this cost or anything else is those long-term, patient finds out they got HIV. Some of those are not included in this. This budget here. And based off of the AABB survey from 2013, the average reimbursement for 2013 for a leukoreduced red blood cell was only at 88.3%. That means that we're losing annually, out of the 6.1 million RBCs that were transfused in 2013, hospitals are losing $157 million. So if we can find better ways to treat patients and we don't have to expose them to such these products where they can die from them, have reactions delayed in patient care, or delay in their care, why not do it? I mean, the cost is not the driving force. It is something that is very important to look at. You also have to look at what are those alternative treatments. Again, is it iron supplements? Is it EPO? There's so many different options, and it just depends on each patient and their clinical picture. And not only that, with all of this, they've also, from the AABB guideline survey report, has also noted that there's a 24.9% reduction for donors. So we're also we have less blood than we did in 2011, and they anticipate that the numbers will continue to go down. So if they go down, what are we going to do? We need to find alternative treatments and have those readily available for patients. Patient blood management covers a wide range of issues in transfusion medicine. So again, we're not just talking about the hemoglobin levels, but we're looking at, how can we prevent those unnecessary transfusions? How can we reduce costs? And the really big key, the tool here is we got to find specialists. We got to find people who know the answers to this, instead of just having one ER physician or one primary care physician trying to treat these patients. It's really important that we work as a team, and that's what patient blood management focuses on, as well as diagnostic management teams. So what is a diagnostic management team? It's a team of medical professionals who work together to aid in diagnosis and treatment of patients, reducing unnecessary costs and medical errors. Part of the DMTs must incorporate laboratory specialists and/or doctorates in clinical laboratory science. Why? Well, because clinicians only get approximately 8 hours of clinical laboratory training throughout their med school training, which isn't very much. Can you imagine when most medical laboratory scientists have at least 4 years in clinical laboratory training, and clinicians only get about 8 hours. So lab tests are continuously changing on top of it, so it's so hard for clinicians to remember everything. So why not use those who specialize in those areas and let them help guide the physicians to treat the patients? You have to think about warm autos, hemolytic anemias. What can happen in those cases? Specialists in blood bank can even provide those tools. We can assist identifying what to give, when to give, how much to give, addressing all those concerns. Warm autoimmune hemolytic anemias, you got your hemolytic disease of the fetus and newborn, you have your drug-induced hemolytic anemias, massive transfusions. What do you transfuse, and what order do you transfuse it? Are you a large trauma facility who has thawed plasma, platelets, and red cells in the ER readily available? Or do you work in a critical access hospital where you only have red cells readily available and it's going to take 20 minutes to thaw plasma? Physicians aren't always aware of what the best option is for these patients, and as blood bank specialists, we would be able to help provide the information needed to better care for these patients. Same with, for example, CHF patients. How slowly should they give that? Should they split the unit? Obviously taco is the #1 cause of transfusion-related deaths, so obviously there's something going on here that maybe we need to focus on. Again, also refractile patients who's giving platelets and they're not going up. How do you address that? How would you guide the physician? That's what blood bank specialists are able to do. Are they going to have every answer? No, but that's why you have to work as a team to move forward for the patients. There's also other specialists. You have chemistry, hematology, microbiology, cytogenetics, molecular biology, the list goes on. These specialists are all needed to diagnose and treat patients and minimize medical errors. We have to be utilized more and more. And then we, of course, have doctorates in clinical laboratory science. Doctorates in clinical laboratory science are critical in patient blood management programs and diagnostic management teams. Their skills and knowledge obtained through education and real-life experience allows them to function as a practitioner and as a leader, educator, scholars. They're going to increase efficiency and overall patient outcome and improve timely response. So patients are going to be in and out of hospitals hopefully quicker because they're going to get an appropriate diagnosis right off the bat, and then they're going to get treated appropriately instead of let's run these 10 laboratory tests and yet the doctor still doesn't understand what it is. So we have to work as a team so we can better care for these patients. Ultimately, in the long run, that's what it's about. We don't want to see them keep coming back to the hospital because we can't find out what's wrong with them. And then I just provided a few little examples, not too in depth, but say, for example, you have a CHF patient or a patient with congestive heart failure. Hemoglobin 6.9. Clinician wants to transfuse. He's not sure what to do. Or maybe he's kind of knows, but not everything. So what would we recommend? Might be to transfuse slowly, split the unit, transfuse it over a longer stretch, 8 hours instead of 4. Monitor specific things as well while transfusing, maybe paying special attention to the symptoms associated with TACO, or avoid the transfusion. Do they really need it? Are they bleeding out? Can we give them iron and APO? Why are they at 6.9? Those are important things to know. And this is just one example of where laboratory specialists or doctors in clinical laboratory science can help. Another one, elderly immunocompromised patient has a GI bleed, slow GI bleed at that. Hemoglobin is dropping about a gram every few days. The patient is going in for surgery in just a couple days. Current hemoglobin level is 9.7. Should the patient be transfused? What would you say? Maybe you want to ask more questions. Maybe you need more information. But just on this information, I would say no. Why? Possible adverse effects, exposure to different viruses or bacteria. Again, TACO, death, HIV. I would wait until the hemoglobin was lowered around that 7 milligram per deciliter, unless the patient was truly in distress. In this particular case, it doesn't note that the patient's in any distress, so maybe you should ask that question. Again, this would be a waste of money for both patient and the hospital if the patient really doesn't need it. Another case, 75-year-old patient presents to the ER with nosebleeds that won't stop. Patient presented a few days ago, and the ER physician cauterized the nose. The patient went home, and again, they're back. So, second time around, patient forgot to tell the ER doctor he takes Coumadin. So the physician checks the INR and orders 2 units of plasma to be transfused right away. INR is 3.5. Should the physician transfuse the plasma? Probably not. Again, you got to get more information, but that's what we're here for, is to help guide the physician in proper treatment. Do they just need vitamin K? They don't necessarily need plasma to reverse it, and INR of 3.5 is not that bad in regards to needing to give plasma to reduce that. But again, you have to look at the whole clinical picture, and that's what diagnostic management teams, that's what patient blood management teams, they need to incorporate laboratory professionals so that way we can help provide better patient care for patients. And if you have any questions, please feel free to ask, and you will see all my references here at the end of the PowerPoint. Thank you.